application is certainly a valiant and virtuous one. And you know, technology is exploding at just an exponential rate. We have materials being introduced. We have mechanisms and devices that are being introduced every day. And you know, at some point you need to make a decision on what are the things you want to focus on in your practice in order to try to maintain a reasonable level of excellence. Because we have to be able to discern the difference between some of this technology and the gimmicks and the fads that are out there with our understanding of how this sophisticated system works, these concepts of complete dentistry that Dr. Dawson so effectively teaches to us. These are timeless principles that I think are very effective at measuring whether this technology is actually enhancing our care or whether we're relying on it to try to get us out of trouble. Because technology is great, but at the same time it can sometimes get us into trouble a little bit quicker. I think that the core curriculum, I think that the concepts that Dr. Dawson teaches us are more analogous to an operating system. You know, if you're the computer, this is your thought process. This is how you process knowledge and data that you garner from the patient. And there are some really cool things that are out there, but I think using these principles, this is something you carry through the rest of your career. This is something that Dr. Dawson started teaching 3 decades ago, and the philosophy and approach has been consistent from day to day. System that is scientifically based on the physiology and engineering that allows it to function so very efficiently. You know, we have 3 components here of this system as we understand it. There are teeth, there are muscles, and there are joints. We could start with any one of them, but we're starting with the joint because we're looking for predictability. We're looking for that pinpoint location of where we can begin our design from. This is a very intricate hinge that allows for rotation and dislocation with really very little wear and tear. When we look at the anatomy and the cross-section, I always find this very fascinating because we can draw some conclusions just by looking at this, where the densely corticated bone is on the slope of the eminentia and the head of the condyle, with the biconcave disc that articulates so eloquently between these 2 surfaces. On the anterior aspect, the superior lateral pterygoid muscle that's attached to the disc and the head of the condyle, and the inferior lateral pterygoid muscle that's attached to the head of the condyle to help position that condyle. We have this very vascular tissue, this retrodiscal tissue in the posterior that obviously is not a load-bearing area, and the attachment to the disc and the temporal bone. And this very fine little ligament that you'll see that attaches the disc to the head of the condyle. You know, this functional matrix allows for muscles to function in a very non-antagonistic way with comfort and efficiency. And if this system is designed properly, we understand that there should be bilateral simultaneous contact when the joints are in their hinge axis position, with an anterior guidance that's hopefully then in harmony with the envelope of function that can provide a peaceful neuromusculature that creates an orthopedically stable position. You know, the whole key to this process is this balanced distribution of forces, because muscles are receiving non-conflicting proprioceptive feedback to those sequentially loaded teeth. We know that certain teeth have different proprioceptive feedback to the muscles than other teeth. Anterior teeth will shut down muscles if there are forces that are too excessive. Posterior teeth will respond quite the opposite. So Dr. Dawson has taught us that if this system is not operating properly, that there are consequences of this occlusal instability. The person that certainly has had one of the biggest impacts on me as a mentor is Dr. Dawson. He certainly has launched thousands and thousands of successful careers. His book, the Bible as we've come to know it for occlusion, has now been translated into 14 languages. So his impact now is certainly an international phenomenon. There have been over 40,000 dentists that have made the pilgrimage to St. Petersburg over the past 3 decades. And he teaches us this concept of complete care, of comprehensive care for our patients. And within this protocol, or within this concept, he weaves the mission statement of being anchored in integrity, devoted to excellence, and focused on results. These pillars, I think, are very powerful standards to build our professional lives upon. Dr. Dawson goes on and describes in detail the designs and purposes for each of these surfaces of these teeth in broad strokes. Certainly it begins in a very specific order, and we're going to begin on the lingual surfaces of the tooth where the central holding contact is on the lingual aspect of those teeth. That centric holding contact needs to be a very solid stop where the leading edge of the mandibular incisor is going to find a home. It's not on a noxious inclined plane, it's in a very specific location. From there we go to the facial aspect of the tooth. And with the facial aspect of the tooth, this emergence contour needs to be contiguous with the alveolar process. So as we're designing our treatment plans, we were taught in dental school a three-point health belief model that began with biological health. Biological health has to do with those issues related to bacteria, disease, and infection. We then moved on to structural integrity, to the alveolar supporting process, to the remaining tooth structure. Is it adequate for what we're hoping to be able to accomplish? And certainly the functional health. How do these teeth interact, and is there a functional design that's appropriate? What's new to the scene is aesthetics, and aesthetics is, what's the emotional health of the patient? What kind of self-confidence and effect does the appearance of these teeth have on the patient's sense of well-being? We're now moving, however, to a different place. We're now moving to a point where we're trying to provide aesthetic care. We're now kind of going to an advanced level of treatment planning with an idea of what the final result is going to be in mind. So we're going to break up and turn around this health belief model, and we're going to start with aesthetics. We're going to try to determine how are we going to position these teeth in the patient's smile as it relates to their face. We're then going to modulate the aesthetics with the function. How do we need to alter those contours in order to match the idiosyncrasies of the functional design of that patient? Structural integrity. Do we have support of the alveolar tissues in order to provide this function, or do we need to make some changes? What about the teeth? Are they going to be able to withstand these demands that we're placing on them? And in the end, can we provide an environment that can be cleansable so that the patient can maintain health with these teeth? So when we talk about the architecture of a beautiful smile, you've been through some of this description already as we talk about smile design, but we're going to reorganize it just a little bit, so hopefully it's a little more effective now that you understand these parameters. And we're going to break it down into 3 separate sections, and this is kind of how I've rewritten the criteria guide when it finally comes out. We're going to begin first with global aesthetics. Global aesthetics have to do with unretracted views, photographs without the retractors in their mouths, views that have to be diagnostic, that give us a feeling of the orientation of these teeth as it relates to the face. The next thing that we're going to focus on is macro aesthetics. Macro aesthetics have to do with the shapes and contours of the individual teeth to themselves and to each other. And finally, we're going to focus on microaesthetics, which I think is kind of the fun part. Microaesthetics have to do with those idiosyncrasies or those things that start to make teeth look like teeth. Shade, textures, translucencies, and those kinds of. How this protocol is put together. What are the steps that are necessary that we've learned up to this point? And every case that we're approaching, we're dealing with in 4 specific stages. Obviously, we're garnering all our information that we need to in our complete exams with our radiographs, with our photographs, with our hard tissue and soft tissue exams, and we're beginning to develop our 2D treatment planning. Our 2D treatment planning is those 16 steps, the functional aesthetic checklist, that we are beginning to create a vision of what we want the final case to look like. What are the corrections to the problems? What are the solutions to some of the shortcomings of the design in the case? From there, we're going to move on to our 3D treatment planning. Our 3D treatment planning involves the use of a virtual simulator. That virtual simulator are mounted diagnostic models. It's to those mounted diagnostic models then that we're going to begin to implement some of these changes from our 2D treatment plan. And see how they need to be modulated to fit the idiosyncrasies that are important for that person's function or occlusion. That will allow us to then create a series of matrices, so we can then go to the part that probably is one of the most important parts of the process that we'll talk about late today and mostly, well, actually tomorrow and on Saturday morning, is how do we deal with these prototypes and provisionals to get a predictable result. And then obviously the definitive restorations, which hopefully then give us some predictability based on the decisions that we've made or worked out in the patient's mouth. Because what we have to understand is that our 2D treatment planning and our 3D treatment plan is our best guess of what we think will work in the patient's mouth. We've optimized the aesthetics in the 2D. We've modulated that back in the 3D. We've tested it out in the prototypes. So now when we're into the final restorations, we really should just be tweaking some of the elements of macro aesthetics, maybe some of the elements of micro aesthetics, and then hopefully being able to deliver our final. So we talked about the parameters of materials. A lot of great things out there. It's still about protocol. It's still about design. It's not about bulletproof. We need to still modulate those parameters of what we're trying to achieve aesthetically as well as with function, although that balance is starting to fall more into skew. We now need to take the parameters of those materials and marry them to prep designs. So we're going to talk a little bit about prep designs here. And what we need to keep in mind is that increasingly our preps are becoming more and more complicated. We're just not ripping down the entire surfaces of the tooth and doing a crown. Materials that are available today. And you know, I think our tendency is to look for materials that are bulletproof. What is the strongest material I can use so that things don't break, so that I have success? And as we referred to yesterday, you know, success is more about the whole system at large and making sure you're having a healthy environment, and it's not just broken ceramics and the beauty of the restorations that we're worried about or concerned about. It's the periodontal architecture. It's any of the wear and tear that happens on any of the other areas of the teeth. Those signs and symptoms of forensic activity that are suggesting that there are some occlusal issues going on. So as we talk about some of the ceramic materials and the evolution of ceramic materials this morning, try to keep that in mind because the materials we were using 2 years ago or 5 years ago or 10 years ago or 25 years ago worked fine if you were following these principles and if you understood the process of balancing these forces that can be so destructive in this incredibly inhospitable environment that we're providing our little accessories in. So as we look at restorative material selection, we kind of have this balance going on that we're trying to figure out. Obviously the buzz is aesthetics, aesthetics, aesthetics. I want the most beautiful material possible in order to try to restore my patient's smile. I want very lifelike type materials that have the optical properties so that from an aesthetic standpoint they look like teeth when I'm done. The challenge is we've got a restorative lifespan. We have functional needs. We have force issues that